Hello everyone. We are now going to go over the peripheral blood flow cytometry plots from a 7-month-old male infant who presented with skin lesions and numerous large circulating blasts. Let's start with CD45 versus site scatter. And we have 21% cells in the lymphocyte gate. These express bright CD45 and have low site scatter. And there are 13% cells in the granulocyte gate. The granulocyte gate usually has dimmer CD45 than lymphocytes and monocytes, and they have high site scatter due to their granularity. And we have a huge population here that is painted red. They have called it blast, and it's kind of usually the blast gate is located here that has dimmer CD45 and low site scatter because blasts usually do not have granules. I mean, certain blasts can have granules, but majority of them don't. And the monocyte gate will be usually here. The monocyte gate has monocytes which have bright CD45 similar to the CD45 of lymphocytes, and they have slightly higher site scatter than lymphocytes because of minimal granularity. But here we see a population that is going from the blast gate, and it migrates and merges with the monocyte gate. And this huge population, we cannot separate it as blasts or monocytes. They kind of go all the way up to here. And now let's follow through this population and to see what their phenotype is. These cells express CD34 and CD33. So, I mean, they express CD34, so they are immature. They have CD33 expression, dim CD117, partial dim. They express HLA-DR. They express bright CD15. They are positive for CD38. They're positive for CD13. They are positive for CD11B. They are positive for 64. Almost all the blasts are positive for CD14. There's a small population that is trailing. And they express CD56, negative for CD16. And they're negative for the T cell markers 3, 7, 2, and 8. CD4 is positive. We'll come to that. And then they're negative for the B cell markers 19, 20, and 10. So if we see they're positive for CD34, so there is no doubt they are immature because morphologically we saw large blasts and we have cells in the blast gate going into the monocyte gate, and they're CD34 and HLA-DR positive. So they are immature, and they express markers CD11B, CD64, CD14, and CD4. These are monocytic markers. Now CD4, we usually see them in CD4 positive T cells, but you should also remember that CD4 are also positive on monocytes and macrophages. So monoblasts, promonocytes, and mature monocytes, they all can be CD4 positive. So that helps. And yeah, as long as HLA-DR is concerned, we usually consider them as immaturity marker. They'll be positive on myeloblasts, lymphoblasts, etc. But even mature monocytes express HLA-DR. So when we consider monocytic lineage, HLA-DR is positive in all the monocytic lineage cells, both immature and mature. So HLA-DR positivity does not make it immature. But the CD34 is still an immaturity marker. So here we have CD64, 14, and 11B expression, which are all monocytic. CD14 is specific for monocytes because 11B and 64 can be seen in some myeloid precursors also. Some labs use CD11C as well. That can be positive in myeloids. And CD15 is also another monocytic lineage marker. So CD15 is positive here, pretty bright. So we have a monoblast population here, and monoblasts can be positive for CD13, and they usually express bright CD33. We have homogeneous CD33 positivity here, but usually they can be even a little more brighter. So HLA-DR and CD33 usually are the brightest in the mature monocytes or in the monocyte lineage cells. So whenever you have a monoblast population, usually you will see HLA-DR, CD33, and CD64 positivity, and the others can be somewhat variable in intensity and their positivity. And to call something as a monocytic leukemia, or AML with monocytic differentiation, you need at least 2 of the monocyte lineage markers like CD11B, CD11C, CD64, CD14, CD4, CD36, lysozyme. All these are considered monocytic markers, and you need at least 2 of them on the blast population to call it AML with monocytic differentiation or monocytic leukemia, sorry, monoblastic leukemia. Now, CD56 and CD7 are aberrant markers that can be frequently seen in AMLs with monocytic differentiation. And one other thing you have to remember is, unlike other normal myeloid blasts or neoplastic myeloid blasts, monoblasts tend to have higher site scatter, and they usually are found in the monocyte gate that can sometimes the site scatter even go higher than this and can go up to the roof. So this is usually where they are located. So this is a classic case of AML with monocytic differentiation. CD34 is positive in this case, but they are also commonly negative. You can have them negative. CD117 is negative here, but they are more frequently positive than CD34 in most cases of monoblastic leukemia. Now, how to report these? So these cases we'll report as acute leukemia with monocytic differentiation usually, and we'll leave it there because you need ancillary testing on these cases because a lot of leukemias can have monocytic presentation. For example, AML with inversion 16, AML with NPM1 mutation, AML with FLT3 mutation. So you have to eliminate all these by your cytogenetics, FISH, and molecular test before you call it as AML with monocytic differentiation, NOS, or acute monoblastic leukemia, NOS. So you need a lot of factors there. So for flow, you just have to call it acute myeloid leukemia with monocytic differentiation, and you just give the percentage of the blast, and you give the detailed phenotype. Thank you.